This week's paper is from our friends at the Journal of Isocos, and it tackles one of the questions that ACL surgeons think about all the time, but quietly admit we don't have a clear answer to. What do you actually do when the knee hyperextends? Because every surgeon knows these patients need something a little different or extra, but no one can tell you definitively what the right answer is. It's a Sunday paper roundup where I read the paper so you don't have to. I've not been feeling great the last few days, but I'm a soldier and I couldn't let you good folks down, so here I am. Let's break it down. First, what was studied? This was an international Isocos survey of 427 experienced ACL surgeons from every continent, with most doing at least 50 ACLs a year. Would even higher volumes have been nicer? Sure, but this is still a large group of active, experienced ACL surgeons, so it isn't theory, it's what surgeons actually do when faced with hyperextension or hyperlaxity. First, the consensus. There actually is one. 75% believe hyperextension patients tear their ACLs more easily, and 90% believe they fail reconstruction more often. So the risk signal is universal. That's not controversial. But here's a key finding. Despite that agreement, 2/3 of surgeons modify their technique and 1/3 don't. And that tells you everything. When experienced surgeons agree there's a problem but diverge on solutions, it tells you that the evidence gap is real. So what do surgeons actually change? If we look at graft choice, 38% hamstrings, 37% patellar tendon, 6% only for allograft. So despite believing failure risk is higher, hamstrings remains the most commonly used graft. That's an important disconnect between what we believe and what we actually do. 83% do not change tunnel position, and only 13% move the tibial tunnel more posterior. So even in high-risk knees, most surgeons leave the standard technique alone. If we look at the fixation angle, the majority fix the ACL graft at 20 to 30 degrees, and only 7% fix in full hyperextension. So again, strong opinions, but very little agreement. When we look at extra articular procedures, this is where surgeons really converge. 90% believe adding one reduces failure, and LET is a clear favourite for 2/3. Many use it in more than 3/4 of hyperextension cases, and that tells you something important. When surgeons feel uncertain intra-articularly, they protect the graft extra-articularly. Rehab was another paradox. Most aim for full extension to 0, and only 33% aim to restore full hyperextension. I do. Yet 56% believe patients are less satisfied if hyperextension is restored. So people are knowingly trading stability for satisfaction, and that's because they're not sure where the right balance truly lies. Now the critical appraisal. This is a level 5 evidence, it's a survey. It doesn't tell us which graft is best, whether LET truly reduces failure in this group, or what fixation angle actually works, but here's why the paper still matters. When hundreds of experienced surgeons manage the same problem in completely different ways, that's not noise, that's a defined, unresolved clinical problem. So as always, we finish with my verdict. Should you ignore it, be aware of it, really consider it, or go right ahead and change your practice? And my verdict, be aware of it. Not because this paper gives definitive answers, but because it proves something important. Hyperextension remains one of the biggest unanswered questions in ACL surgery. Until we have better data, your graft choice, your fixation strategy, your threshold for LET are all judgment calls. This paper also does something important. It highlights that uncertainty exists and why that uncertainty is justified. So if you feel uneasy doing ACL reconstructions and managing knees that hyperextend, you're not behind, you're practicing honestly. Make sure to follow for more. I'll see you next Sunday. I'll keep breaking down the evidence as it lands.